Well, hello, everyone. I'm Dr. Lisa Waddell, the Chief Medical Officer with the CDC Foundation. It is my pleasure to both welcome and thank all of you for attending today's webinar focusing on children and the COVID-19 vaccine. The CDC Foundation is so pleased to host this webinar in partnership with the Vaccine Equity Cooperative and Health Leads. The webinar is the 7th in a series for community-based organizations. It is part of the CDC Foundation's ongoing work and commitment to support those of you working in communities and partnering with communities to fight this pandemic. We all know that this pandemic has taken a terrible toll on the health and well-being of so many, and that includes our children. Far too many children have been sickened by this deadly SARS-CoV-2 virus, and sadly, too many have died. And it remains to be seen how many may be impacted by the long-term consequences of the virus. But the long-awaited prevention tool is on its way, and that is a COVID-19 vaccine, specifically for our young children ages 5 through 11. So today's webinar will focus on planning for the child ages 5 through 11 for the COVID-19 vaccine rollout, equitable approaches, and best practices. We are thrilled to have a number of experts, speakers on this topic for today with us. So to get us started, I will turn the program over to our moderator, Ms. Tanae Hamilton Franklin, the Vice President of Health Equity and Stakeholder Engagement with Health Leads. Tanae.
Thank you, Dr. Waddell, and welcome everyone to our conversation today specifically focusing on the child vaccine rollout, equitable approaches, and best practices. Now, before we get into our conversation, I just have a couple of housekeeping notes. One, use the Zoom chat to submit questions, comments, reactions, or resources to share with each other. The webinar is going to be recorded and we will send it out afterwards, and it will be uploaded to the CDC Foundation website towards the end of the week. This webinar also has closed captioning available. To enable closed captioning, please click on the closed captioning icon to turn it on. So let's jump in. We know that the FDA emergency use authorization for COVID-19 vaccinations for children under 12 is right around the corner. It is, as anticipated, some parents will be eager to vaccinate their children, but we also know that there's about 34% of parents, according to the Kaiser Family Foundation, say that they're going to wait to vaccinate their children under the ages of 12. So pediatric practices, health departments, FQHCs, and also school-based health centers, many community-based organizations are preparing for the challenges of vaccinating children and families. And we know that these conversations and preparations are going to be most effective on the local level. In addition, I wouldn't be surprised if some of us were also wearing our parental hats today to learn some more information on how to navigate this conversation with our own families. So for patients under the age of 12, we need trusted messengers. We need effective communication. Community-based organizations with schools and also medical homes, all of these players are important and play critical roles into making sure that we have solutions for our community. So in today's conversations, we're going to focus on centering on racial health equity solutions while addressing root causes of disparities, prioritizing outreach in the context of local families and communities. We're going to talk about building on existing infrastructure with an open mind to no wrong door approaches, and also engaging allies in the medical and public health community, schools, health policy, and private sectors. Resources to help community members and families make an informed decision are also going to be shared not only by our speakers today, but I also know that a lot of you all have those resources. So again, I encourage you to drop them in the chat. Our Health Leads team is going to help vet those resources and make sure that we include them when we send out the webinar information after the call. So I would like to go ahead and introduce the speakers that we're going to have up front. First, we have Dr. Kevin Chapman-Stevens. He's with the Pediatric Vaccine Planning and Implementation Lead with the CDC's Vaccine Task Force. We have Dr. Lauren A. Smith, who is the Chief Health Equity and Strategy Officer for the CDC Foundation. We have Ms. Venus Gines, who is the president and founder of Dia de la Mujer Latina. Mr. Robert Boyd, who's president and CEO of the SchoolBased Health Alliance. Mark Del Monte, CEO, executive president of the American Academy of Pediatrics. So that being said, I would like to go ahead and jump into the conversation. And Kevin, I'm going to turn it over to you to share from your perspective how CDC is approaching the vaccine rollout. Kevin.
Great, thanks so much, Tanae, and good afternoon, everyone. Really wanted to thank everyone for the opportunity to speak with you all today. As mentioned, I'm Kevin Chapman-Stevens. In my current role, I'm helping with the planning for the COVID-19 vaccine for children 5 to 11 years old. And I think we all know that a lot of families, pediatricians, teachers, and others are eagerly awaiting this vaccine. On a personal note, I'm a pediatrician and have several nieces and nephews that fit in this age range, so I'm personally and professionally vested in this activity. As already been mentioned, we unfortunately know that children have been directly affected by COVID-19 by getting sick, some unfortunately severely sick, and also indirectly affected as well through family members getting sick, missing out on school and other key activities, and being behind on regular medical care, including routine childhood vaccinations. And so vaccinating children can really help protect them from getting COVID-19, as well as protecting them from severe disease, hospitalizations, or developing long-term COVID-19 complications, and really allow us to begin to return to pre-pandemic life. With many children back in school and participating in extracurricular activities like my own children, COVID-19 vaccination among children is even more critical to preventing infection, as well as reducing transmission of COVID-19, especially with the widely circulating Delta variant. So many folks are asking, well, when will this be available for my children, my grandchildren, my patients, et cetera? And so, just to set the stage here, COVID-19 vaccination among this age group is subject to authorization by FDA and also by recommendation by CDC's Advisory Committee on Immunization Practices, or ACIP. And this is the same process that's been followed for all the other COVID-19 vaccines, as well as for all routine childhood vaccinations as well. I know a lot of people are also interested in a specific timeline. So we know the FDA's Advisory Committee will meet on October 26th, so less than a couple weeks away, to discuss the data behind the Pfizer vaccine in this age group. Sometime thereafter, either later that week or early the following week, it's anticipated that FDA may make their announcement, may approve the vaccine. And then CDC's Advisory Committee, or ACIP, will meet to discuss the vaccine and offer their own recommendations. That committee is currently scheduled to meet on November 2nd and 3rd, but that could be moved up or back depending on when FDA makes its announcement. So the decision by CDC and FDA regarding the use of the vaccine among children will follow an in-depth review of available data on safety and how well the vaccine works in children. On the safety note, it's important to note that COVID-19 vaccines have undergone and will continue to undergo the most intensive safety monitoring in US history. We know that some parents may have concerns regarding the safety of these vaccines, so we'll be messaging to families on this topic. In addition, we always encourage families to discuss any concerns with their pediatrician or whoever cares for their child, as that clinician knows the child and the family the best. We've also been working very closely with health departments and clinicians to make sure everyone is prepared for the release of the vaccine. For example, this past Friday, we sent out a planning document with some information on the vaccine to our health departments and clinical partners, and we'll be sending out more information this week. And to ensure equitable vaccine distribution and administration, CDC plans to ensure broad and convenient coverage by having vaccine available in different locations, including pediatricians' offices, pharmacies, vaccine clinics at schools, et cetera, to monitor vaccine administration trends early and often, and to disseminate culturally and linguistically appropriate messaging through trusted channels. Ensuring equity in vaccination coverage is a high priority for CDC, and there are some groups of children who made additional consideration for COVID-19 vaccination, including, but not limited to, children who may be at increased risk for severe COVID-19, children with limited access to routine vaccination services, such as those who are experiencing homelessness, who live in rural areas, or who have special healthcare needs, children who experience systemic health or social inequities, such as racial and ethnic minority groups, households with lower income, and children with disabilities, and also children living in congregate care settings. We really appreciate all the work that y'all are doing to help ensure that our children can be vaccinated. Everyone on this call is a key partner in this effort and can help ensure its success through a variety of activities, including amplifying messages to families and communities and leveraging your trusted partnerships. With that, I'll go ahead and end and just wanted to say thanks so much. Appreciate it.
Thank you, Kevin. I know we're going to have some questions during our question and answer session after we hear from the speakers. Next, I'd like to bring up Mark Del Monte. Now, Mark has to leave for another meeting in about 15, 20 minutes. So we're going to hear from Mark, and then I'm going to ask Mark just maybe 1 or 2 questions if we have time, because I know you have to leave the call early. Mark?
Super. Thank you so much. And what a privilege to be with you. I'm just delighted to have the opportunity to address you for a few minutes here. It's a busy time at the American Academy of Pediatrics, and so I'm not going to be able to stay for the whole time, but I'm sorry about that, and I hope I get invited back. We'll see how I do here. I'm Mark Del Monte. I'm the CEO of the American Academy of Pediatrics. I'm a lawyer, not a pediatrician. There are 2 pediatricians on the panel today, so I'll leave you in their good hands too. AAP is 67,000 members across the country, and this is really the backbone of where children get vaccinated. And we have begun to think about this, I think, in terms of 5 to 11-year-olds in 3 different categories that I think are quite important. The first category is some of the things that Dr. Chatham-Stevens just mentioned, which is how do we get the vaccine to the places where people want it? So at some point in the next couple of weeks or so, the federal government will make a decision approving, hopefully, a vaccine for 5 to 11-year-olds. And so wherever families want to get that vaccine, or if they want to talk to their clinician about that, we've got to get all of that distribution ready and pre-positioned so that it is ready to go as fast as we can have it as soon as that decision is made. So that for us is really logistical questions about where are the vials, how do the vials get from where they are now to where they need to be, how do practices work with their state immunizations, public health officials and public health districts in their jurisdiction or state to get the vaccine into the practices so that they can be ready to administer to children as fast as we can. It's going to be very important to communicate to people that the vaccine that is contemplated for 5 to 11-year-olds is different. It has a different vial and a different formulation, so we can't use the vaccines that are approved for 12 and ups right now on 5 to 11-year-olds. So we're going to have to wait for the vials, the new vials with the new formulation to get into the places where vaccines are distributed. That's going to be a hard distinction for people because I think we're going to have to, for that initial rush, people are going to want to get it right away. And if you've got vaccine in your office, why can't you just give me what you have there? So I think that initial distribution is going to be very important. That time over the next few weeks or months when demand exceeds supply, where people who want to get the vaccine for their child right away, we want to be able to get that to them. So I think that there's a lot of issues there and a number of things that we're working through. Once we get past that initial period, I think we really need to think carefully now about what that is going to look like. And what I think that's going to look like for most families or many families is the same kind of barriers to access and common concerns that they have about vaccination right now. And we know that we're at least 10 or 11 million doses behind in routine childhood immunizations. And so we need to have a conversation to get families back to where they get vaccines, to get caught up and to get the COVID vaccine as well. I think it's a mistake if we think that there's vaccines over here for children and then the COVID vaccine over here as somehow distinct. I think as we're talking to families and talking to communities about vaccination, we need to increase confidence and share messages that bolster the confidence in all vaccines, not just the COVID-19 vaccine. So thinking about messaging will be very important. People who give vaccines to children know how to talk to families. Families have lots of really heartfelt questions about every single intervention that happens to their child. What parent doesn't want to know every detail about what's happening to their child, whether it's a vaccine or a prescription or going into the hospital or anything else? And so we have to be ready to deeply discuss their issues, answer their questions one at a time, family by family, to have those hard conversations. And we know that the more local and then the closer to the family those messengers are, the more persuasive they are. So we've got to think about having conversations that are really, really close to the community and really, really connected to the family. So how do we make sure that all those messengers are ready to go? And then I think the third category is there's an organized effort to undermine confidence in vaccines by people who want to bring down the vaccination system, and they certainly want to undermine the COVID-19 vaccine. And this is very dangerous. And this information is organized and moving quickly, literally at the speed of the internet. And so we have to be ready to not only counsel about safety and efficacy of the vaccine, but counter ugly misinformation that is being spread on purpose. And so I think those are the three kind of categories that we're worried about as we approach this. It's sort of go time for the 5 to 11s. And so we're thinking about all of those aspects right now. But what I can say just in closing of the summary here is we should begin with the end in mind. And if we want to reach those populations who have real questions about healthcare and accessing healthcare, who have real questions about new medical interventions, we're going to have to think about that now. So that means beginning the conversation before the EUA is even granted about equity and about making sure that distribution of the vaccine gets deeply into communities and that messengers who are bringing those messages into those communities know what they're doing and know how to have authentic conversations with people. We've had tremendous success. We've seen people like the conversation on YouTube. There are a number of people who've really been working very hard to do this. And so I think we can amplify and bolster those efforts, particularly as we get down to the younger children. But we all have a lot of work to do together on the logistics and on the messaging, and then countering the terrible disinformation that is flowing freely if we're really going to get as many of our children vaccinated as possible. So let me stop there and maybe take some questions if that's okay tonight.
Thank you, Mark. So the first question, I'm wondering if you can talk a little bit about how we should think about pediatricians engaging with health departments specifically. So we know that pediatricians are trusted messengers. We know that health departments are driving a lot of the vaccine efforts in local communities. So talk to us a little bit about how we should be thinking about that.
Yeah, thank you. That's a great question and a really important concept. One of the infrastructures that's currently in place is the Vaccines for Children program, which is a nice interaction between state health departments and those programs and the field and pediatric practices. Right now, we know that the average is about 75%, but there's some differentiation across the states. But in some states, almost all of their VFC providers are signed up to be COVID-19 vaccine administrators. And so I think the immediate bridge that needs to be built is between the VFC program, because those providers know how to interact with state health departments. They know how to have the conversation about ordering and getting sufficient supply and getting all of that distribution mechanism working to get actual vaccine into their office, into their refrigerators, and ready to go. They know how to do appointments and all the kind of administrative aspects of scheduling vaccinations in their offices. And so that's built infrastructure that we have right now. And so to the extent to which we can leverage that infrastructure quickly to work for the COVID-19 vaccine, I think that will be crucially important. For those practices that are not VFC providers, I think we're going to have to encourage them working with our state chapters in every state to get those connections in place. The nice thing about pediatrics is that they're high volume vaccine administrators. And so they know how to do this. We just need to figure out how to ease the way for COVID-19 vaccine to get into those practices. There are differences in payment, there are differences in ordering, there are differences in storage. So we've got to work out some of those logistical differences along the way.
And then just a follow-up question, how is the American Academy of Pediatrics, what role do you all play in communicating, informing, advocating with pediatricians that they go ahead and make sure that they become VFC providers? So we know that that's what they need to do, but are you all doing anything to encourage that, particularly those in vulnerable communities?
Sure. Thank you. You know, the data is clear now that 51% of children are on Medicaid or CHIP. So the implications of that more than half of kids are now covered by by public health insurance through Medicaid or CHIP, means that half of kids are living in families that qualify for those programs, which means that they're in poverty or near poverty. And some CHIP programs are just above the federal poverty level or a little above it. And so we have to build the whole system in a way that recognizes that that's who children are and the care that they need. And so our members, and our pediatrician members, have to not only be a part of the VFC program, but they also need to be a part of the Medicaid and CHIP program, because that's where the kids are. So I think we can build out an infrastructure that serves all kids. It's our role to do that as the standard setting organization. For pediatricians, we create guidance and policy, and so we sort of set the gold standard for the practice of pediatrics. We issued a policy statement recommending the vaccines in 12 and ups when that EUA came, so that the formal stamp of this organization on that vaccine accompanied the CDC and FDA's approval of it. We have every expectation that we would do that for the next EUA for 5 to 11s. And then there's a whole advocacy component. We need to set the conditions so that people in practice that the ecosystem can work. And so if you have Medicaid systems that are strapped or VFC programs that are underwater, that doesn't work for anybody. And so we've got to build out these systems to make sure that they are able to receive kids and families, and that children and families are in the center of them, and all the service providers wrap around the outside, as opposed to forcing families to negotiate all these complicated and hard systems. So I think we have our work cut out for us to encourage people, but also to change the systems so that they're more friendly to families.
Thank you, Mark. I know we're going to have questions for you, and I know you have to leave. Would you mind if we forward those questions to you for a response that we can send out later on to our viewers?
I'd be delighted. I'd be delighted. Right. Thank you so much.
Appreciate you. All right, next, Dr. Lauren Smith from the CDC Foundation.
Thank you so much, Tanae. And I want to echo Mark in saying I'm so pleased to be here with so many of you in addressing this really important and critical topic. So I wanted to use my time to outline why we know an equitable vaccine distribution is so important for our kids. I wanted to just take 1 minute to level set. I'm sure I don't have to convince any of you all about this, but we know that there's been a disproportionate health and well-being impact on our children of color in the US. Their physical health, we know that these kids have lower rates of testing, they have increased rates of infection, they have increased rates of admissions to the hospital and then to the intensive care units, and they have increased rates of serious and life-threatening complications, such as a multi-organ inflammation syndrome that happens in children. And not surprisingly, and most tragically, they have an increased risk of death. So the death rates of American Indian and Alaskan Native and Black children are 3.5 and 2.7 times higher than their white counterparts. So we know that these populations of these communities of children are already experiencing disproportionate impact. And so it's essential that the vaccine that can prevent and protect them really needs to be equitably distributed. We also know that the pandemic has had unequal impact in terms of emotional health and educational and academic progress. with family stressors related to parental job loss, housing instability, as well as the illness and death of loved ones, since these same adult communities have also experienced disproportionate loss. These kids really have had significant trials and tribulations in their lives to contend with. And they're also the same kids who were at increased risk for learning loss and achievement gaps before the pandemic. And so you set that up and add to it that they're more likely to miss schools and have had difficulty accessing, fully accessing remote and virtual learning for a whole host of reasons, means that they are at increased risk for educational disruptions that are currently happening when schools are closed due to outbreaks or the circulation of the virus in schools. So we know that 23% of parents overall have indicated that their child has had to be quarantined at home due to exposures at school. And again, this just adds further disruption for kids who are already at risk for educational difficulties. Now, what do we know about the parents' attitudes about vaccination? Not surprisingly, parental vaccination status is a strong predictor of whether or not they intend to vaccinate their younger children. It's already a strong predictor of the vaccination status, that is, of their teenage or children, ages 12 to 17. So we know that we have to, it's not about only reaching the kids, right? It's about, reaching the parents and being sure to address their questions, which I'm going to come back to. Tanae mentioned in her remarks that the Kaiser Family Foundation noted that 32% of parents of this age group had a wait and see approach. Now, 34% said that they would be willing and interested to get their children vaccinated as soon as possible. But there's also 24% who say definitely not. So as we go forward with this planning, we do need to continue to think about how to reach the parents in each of those categories. We also, in the Kaiser Family Foundation work, saw that mothers more than fathers, Latinos more than some of the other racial and ethnic groups, and parents with lower income are the most worried that their child will actually become sick from COVID. More than 70% of each of those groups express fear that their children will become sick. So what are the barriers to access? We've talked about why this particular population and groups of children have a disproportionate burden and why it's essential to reach them with equitable outreach. We know that vaccine attitudes of parents have a big impact. What are other and very important barriers to COVID vaccination? And as Mark mentioned in his comments, they really follow the same patterns as the barriers to all healthcare for children. One is the ability to get the vaccine from a trusted source. Do you have a medical home, and do you have easy access to that medical home? There are concerns about out-of-pocket costs. Mark mentioned insurance status and insurance covered. Even though these vaccines are actually free, parents may not be aware of that, and so they have concerns that they're not going to be able to afford it. Then there's difficulty traveling to get to the vaccination sites, which is always an issue for parents. And last but not least, the difficulty in getting time off work, especially those lower wage workers who do not have paid sick or family leave time, so that if they miss work, they miss income, needed income that's essential for taking care of their families. And so that's a really big barrier for many families. So in addition to that, families have very specific concerns about this vaccine that pediatricians are going to need to address, and then Mark just alluded to. So things like, what's the safety and effectiveness of this specific vaccine? Mark has outlined a lot of information about that, and pediatricians will need to be able to describe that and allay and respond to fears and concerns. Being able to talk about rare side effects. Some of you may have heard about two very rare conditions of the inflammation of the heart muscle or the lining around the heart, called myocarditis and pericarditis, that have been associated with one of the vaccines. The issue is that hasn't gotten as much attention is that those very rare side effects are actually less common than with the disease itself, and that COVID itself is of much higher risk than the vaccine. So we have to be able to put even these rare complications, very, very rare complications, in context of what we know about how the actual disease plays out among children. There's the ability to receive the COVID vaccine along with other vaccinations. Now, Mark mentioned that children are missing millions of vaccinations that they haven't received because they didn't go to their usual sources of care during the pandemic. So it's really important that they get those catch-up vaccinations, and that is possible with COVID vaccinations. And then addressing the myths and misinformations that people are coming into this time of consideration with, and being able to not make people feel ashamed or feel, unintelligent because they've believed these, or they've been taken in by some of this information, because it's been very aggressively and effectively spread, but rather to sort of partner with them and to help them understand and to show them the actual and true information. And then, of course, the implications for their unique child. Parents want to know, what about my child? Not all children, not even all the children in a study, but what about my child with his or her unique issues, unique health concerns, unique educational situations, et cetera. So pediatricians and others are really in the best position to be able to respond to those kinds of questions. The last thing I want to just mention is around the collaboration and coordination among local and state partners who are all part of the public health fabric in communities. So, Tanae already mentioned that ensuring that equity is a key priority and woven throughout. Hopefully I've made the case and you would already have been willing to accept and promote the idea of why equity is so important. And the focus on whole families. I talked to you a little bit about how important the parents' vaccination status is. So we have an opportunity to vaccinate the child and the parents together, if at all possible. That's really helpful because those two things are related. So the next is sort of identifying key partners to be involved and to identifying who's going to be the lead planning entity or organization within the group. So we talked about public health departments, really essential. They are the backbone of public health at the community level. They really can help support connections between schools and medical homes, do other kinds of coordination like mapping vaccine sites to ensure that they're fully and easily accessible to those communities who need the most and who've experienced the deepest impact. So they're key. Community-based organizations, like many of you on this call, are instrumental because you can assist in doing outreach to families, connecting them to medical homes and to other sites for vaccine services, but also to partner with public health and pediatric providers to host in-person or virtual town hall kind of sessions to allow parents to ask those questions in a familiar and comfortable setting, even if they don't have a medical home. Pediatric healthcare providers and medical homes obviously are key, and I don't have to reiterate anything that Mark shared about why those who are at community health centers, federally qualified health centers, tribal clinics, and all the other places where children receive healthcare have to be involved because they are the places that families are most comfortable going for these kinds of services. But there will be additional health settings like pharmacies that many states may choose, and so they need to be part of the planning and be sure to be prepared for doing vaccination for younger children, which is quite different than doing vaccination for middle school age or older folks. Schools and school health. I'm not going to delve too far into this because I know my panelist colleague, Robert Boyd, will be talking about that, but they are such an important bridge to families for those children who don't have a medical home. And there are already successful strategies that exist for doing flu clinics in a school-based setting. So those are things that can be drawn upon. And there's a track record of being able to partner with health departments, hospitals, and other healthcare providers to be able to do that. And I don't want to leave without mentioning the private sector. Business, employers, and others are key to this because they need to be able to provide paid time off, perhaps even co-hosting full family vaccination efforts for their employees and their families, but to ensure that they're doing their part in supporting vaccination at the community level. And last but definitely not least, the ensuring that local trusted community messengers and ambassadors have accurate information in the languages that are relevant for individuals at a literacy level that's appropriate so that they can, in fact, provide the information that's necessary, but also help connect people to the vaccine resources that will be available.
Thank you, Dr. Smith. We're definitely coming to you for questions in a few minutes, but I think this is a good segue. And Robert, I'd love for you to talk about the School-Based Health Alliance and how we should think about using school-based health as a strategy.
Good afternoon, wherever you are. I bring you greetings from the School-Based Health Alliance, and I want to offer a warm thank you to all of you for everything you do every day. You're the front line. I can see from the chat that many of you are practitioners in the field. Also want to thank Health Leads and the CDC Foundation for giving all of us this forum. It's all about the kids. That's why we're here. Real quick, the School-Based Health Alliance is the intersection between public health and education. We're a 25-year-old organization. Although we work very closely with our partners in school health, the nurses, psychologists, counselors, and social workers, our field school-based health centers offer primary care, behavioral health, oral and vision care in clinics in schools. That's what sets us apart. Now, while I don't work for the CDC, I'm a big fan, and as such, I will be citing several resources from the CDC. I'm going to talk a lot about what Mark called infrastructure. My presentation will be available, I believe, post-webinar, and I've included some links to some of the resources that I've listed in the presentation. Let's get started. Next slide, please. It's always nice when others speak well of your work. Several years ago, CDC's Community Preventative Services Task Force issued a guide showing evidence that school-based health services are effective, and in this context, particularly around vaccinations. They also noted that children from low-income communities don't have a usual place to get healthcare services. School-based health services, they said, are beneficial in reducing health inequities. The other thing we want to talk about today is equity. Health inequities in underserved communities. They also noted what we all know. Healthy kids learn better. Next slide, please. But here's the problem. There are about 100,000 K-12 public schools in America. About half of those schools have 50% of their students on free and reduced lunch. We call those Title I eligible schools. And about 1/4 of all K-12 public schools serve communities where 80% or more of the students are from low-income families. They are called fully Title I schools. Now here's the rub. There's only about 3,000 school-based health centers, and that's not enough to serve the need. Our goal at the School-Based Health Alliance is to help place a school-based health center in every one of those Title I schools over the next decade. We hope they'll be called community schools by then. So I know you're asking, in the middle of the pandemic, given the shortage of school-based health centers, what do we do in the meantime? Next slide, please. School-located vaccination clinics, or SLVs. Why SLVs? They're on school grounds. They're primarily designed for vaccinations. They can be structured to serve the schedules of students, families, and school staff. They use a whole community approach to addressing the need, and this approach is critical because every school community is different. The solutions must be tailored to each community. Those of us in the school space often say, if you've seen one school, you've seen one school. There is no cookie-cutter approach to this. Let's make the resources available and let the local communities improvise to meet their needs. As Mark said, there are no wrong doors. Okay, you say, but why schools? Next slide, please. Because that's where the kids are. It's also more convenient for families, and these school-located vaccination clinics, they're set up to administer vaccines. That's what they do. Next slide, please. So you ask, who's going to operate these clinics? Well, our argument would be community and federally qualified health centers. Why community health centers? And I'll use that interchangeably with FQHCs, because they're already located in 61% of all US counties. And the feds just gave them a bunch of money in the COVID relief packages to boost their abilities to serve those communities. You'll also note that almost 2,000 US counties in which there are federally qualified health centers, but only 600 plus of those counties have school-based health centers. With congressional support, HRSA and the National Association of Community Health Centers are rapidly seeking to establish more school-based health centers. Why? Because school-based health centers are effective. Yeah, you say, but can anyone set up an SLV? Why specifically community health centers? Next slide, please. CHCs serve over 30 million people in low-income communities. Most of the CHCs are already enrolled in the Vaccines for Children program that Mark spoke about earlier, that's administered by the CDC. They are a trusted resource in those low-income communities with the emphasis on trust. They focus on patients using Medicaid or those without any insurance. They offer a broad array of primary, behavioral, and preventive care services. They are a one-stop shop for healthcare in low-income and underserved communities. They can serve the entire family. They could deliver those routine vaccinations that Dr. Smith was speaking about, as well as wellness checks as they do COVID vaccines. And they are our first line of offense, not defense, offense in attacking healthcare inequity in low-income communities. Yeah, you say, but why community health centers and schools? Why not set them up in shopping centers or other locations? Next slide, please. We've already stated that schools are the best opportunity to reach students. That's not our words, that's CDC's words. And the CDC has already stated that school-based health works, and Congress has already funded billions to community health centers to support vaccinations and expand those services. The infrastructure is there, let's use it. Please know, I know people often want to draw barriers between us. They want to put us in silos. There are no silos here. We are huge supporters of pediatricians and family physicians. We agree that many families will get their shots in pediatricians' offices. They are a trusted source for healthcare, and this is indisputable. Sometimes, if families in low-income communities have access to private insurance, they may opt to go to a private family physician to serve the entire family out of convenience. Unfortunately, though, a lot of private physicians don't take Medicaid. And as CDC shows, most underserved communities rely on the public sector for their care. By pairing community health centers and Title I schools, we will address the needs of underserved communities. This partnership will be even stronger if we can engage local pediatricians, family physicians, private pharmacies, public health agencies, and hospitals in this effort. We need to use every channel available to us to reach the most vulnerable, our children. I'm here to state the case that in low-income communities, schools and community health centers working together are key partners for overcoming mistrust and hesitancy. Parental consent will be a roadblock. Schools routinely seek and gain parental consent for a variety of issues. Let's all work together to wipe out this virus, and remember, there are no wrong doors. I'll yield back the balance of my time.
Thank you, Mr. Robert Boyd, School-Based Health Alliance. Venus, we're coming to you. I know that you've heard a lot of information, and you're representing the promotoras and community health workers and the work that we're doing in the field. So I'd love to learn more about your perspective on this conversation.
Well, for those of you who know me, it was really hard for me to just put like 4 hours of training into just these few minutes. So bear with me. I put our website there on the chat for anyone who wants to look at our training curriculum. But more importantly, my favorite topic is promotoras and community health workers are community influencers. In 1997, our organization founded Dia de la Mujer Latina. The reason we have Mujer Latina is because we wanted to focus on the mother. In our community, the mother is the one that really makes all the decisions when it comes to health and wellness and also education. So we started the Dia de la Mujer Latina Health Fiestas, and then we complemented that with a promotora training. Fast forward, our training was really focused on chronic diseases and infectious diseases. And in 2014, we started to look at vaccines in general to start introducing the concept of vaccines in our community. And we had our guru, Robin Carlyle, who is just amazing, started to teach the class, and it became part of our training curriculum. In Texas, we have a certification training approval that we are able to train in Spanish and English to all throughout the state of Texas. Of course, as you can see here on the map, our training has been all over, not only in the United States, but in Puerto Rico, Dominican Republic, and in Mexico. I wanted to also share with you that in 2016, we saw what was going on with Zika, and we trained our community health workers. We had our health VSs, but we used these strategies of going to all the WIC offices to talk to the mothers about Zika, and we had little kits for them to take home that got them a little prepared how they were able to prepare their own home. And but from the beginning, what we were looking at is reducing some of the health disparities by addressing the social determinants of health. We have seen this all across the board with chronic diseases, especially with cancer, diabetes management, but right now with COVID. And for this reason, when on February 12th, when I had this training, it was all because I thought, well, I have to prepare them for what I hear in the news about this what's going on in China. Little did I know that it was going to be a full-blown pandemic. So our community health workers by March 15 2020, they were already trained. We had already trained about 3,000 by then. They were already trained, willing, and able to get on the streets, get on the road, and start talking to our community about dispelling myths and rumors about COVID-19. Our whole goal was really debunking misinformation. We realized then that we had some issues with all of the promotional material that started coming out. It was literally translated. Some of the material, we kept saying, oh my God, Dios mío, some of this translation does not resonate with our community. Why? Because we really have only 15% Hispanics in this country. We have 85% Latinos. So when you're developing any kind of promotional material, have images, not just all text. Make sure the language is at a level that people can understand. And more importantly, literal translation can be very dangerous. And we've seen that over and over again. Please go to one of your community organizations, grassroots organizations, and ask them, this is what I like to share with the community. Do you think that this translation will work? Let us tell you if it's going to work or not. Don't just spend millions of dollars putting out all these infographics and all this information out there that our people are not going to read. If you would have gone to those grassroots organizations, our promotoras and community health workers would have been able to tell you that's not going to fly in my community. So this is one of the things that I'm hoping to share with you. The success of our program is not only that we have these promotoras and community health workers that are trained 160-hour training, 8 core competencies for us. It is a bilingual training. It's available nationally. But more importantly, we have now a telehealth community navigation center, call center. We are listening to our community health workers and our promotoras all over the country. We are also listening to our people. We're able to navigate our people, doing warm transfers, helping them, making sure that they have an appointment to get either the testing back then or now the vaccine. There's a lot of misinformation, and we are constantly battling the misinformation, also that's the misconception that's coming even from our government websites, our pharmaceutical websites. We really need to make sure they start working with promotores and community health workers. We can tell you exactly if this information is understandable, it is something that is user friendly. And again, going back to the social determinants of health, health literacy is key here. if we want to just put something out there and you think it's going to fly with your community, please, if nothing else today, go to your promotora community health worker organization. And if you need to find one, call us, send us a message through our hotline. But please, we are in touch with the National Association of Community Health Workers. They also have a great website with a lot of good information. But please integrate us into your field. And I could see here, I know I'm trying to do this as fast as I could because I know about time, but as you can see from the images here, this is all the training we have done. We have trained our community health workers not only about dispelling myths and rumors about Zika and about COVID-19, but also we have also trained them about behavioral health. And that's why we have set up a special training on behavioral health community navigators. We also have a special training for our school-based navigators, those that are really are committed to working in the school system. So Robert, I'm there with you. We need to have our promotoras and community health workers in the school system. I agree with you. And finally, our clinical trial community navigators. We need more people to understand the value of research. Did I go over?
Ooh, you're good. No, so I need you to breathe. I need you to breathe, Venus, because we're going to come back to you with questions. So thank you for our speakers for getting it started, and that conversation, what you've shared has probed a ton of questions coming through the chat and also lots of good information. But let me start with you, Kevin. We're hearing a lot of questions that I think CDC can just answer on its own. But I think the most pertinent questions that I'd like to start with, one, if the vaccine formula is different, is it still produced by Pfizer? So tell us a little bit about the vaccine formula, the dosing, so we can sort of better understand how to plan with regards to the pending FDA early use authorization.
Sure. So I mentioned this in the chat, but some of the information regarding the vaccine characteristics, such as dose, if you need to use a diluent when you're preparing the vaccine, et cetera, will be forthcoming. We're trying to get that information out to help health departments and clinicians prepare for this. So we hope to send that out shortly. And this is all definitely pending FDA authorization. So FDA has the final word on that kind of information, but we will be pushing out that information as we get it.
All right, great. My next question for you, could you tell us, actually, this is, Lauren, this is for you. I was wondering if you could maybe give us a little bit of information on how we should understand the risk difference between myocarditis and myocarditis for children from the COVID vaccine.
So there's a couple things to keep in mind. When children have COVID, are infected, and have experienced COVID, they are at risk. Oh, I'm so sorry for that. It never rings except when it needs to not. They're at risk for complications simply from having COVID. So one of the serious complications that I mentioned is this multi-system organ inflammation that can affect brain, lung, kidneys, heart. And as part of that, you can get that same kind of inflammation of the heart muscle and the linings around the heart. That's from the illness, the sickness with COVID itself. My point was that those kinds of complications are more common than any complications from the vaccine. And there's good data to support this, especially the very rare side effects that people, I think, might have heard about, the myocarditis and the pericarditis. So the bottom line is, it's important to, of course, be aware, but one has to weigh and compare the risks of having serious complications from the disease itself to having complications from the vaccination. And my point is that the risk of having complications from the disease itself is much higher. So it's really my recommendation as a pediatrician and a mother for folks to get vaccinated, because that's the way you can protect your children from these very real complications.
So I think I take it for granted that I can just pick up the phone and call my pediatrician and ask a question about my child and how I should understand the vaccine for their health. But for those that are not plugged in to regular pediatric visits, the school-based health centers seem like it's a really good option. So Robert, I was wondering, and this might also be for you, Kevin, how do we think about parents being able to ask for information to better understand how the vaccine might affect their child's health if they are seeking or using the school-based health centers as their primary source of information and getting the vaccine?
Yeah, school-based health centers are generally, for the most part, not staffed by physicians. They're generally staffed by nurse practitioners and physician's assistants who are very, very well trained and can answer a lot of these questions, as can their school nurses. And they should go to the person or persons that they trust and ask those questions openly, honestly, and confidentially. The data's out there. Vaccines work. And overcoming this hesitancy is going to take getting parents to communicate with professionals that they trust who are in possession of good information. A lot of us know there's a lot of people out there spreading bad information, but schools are a place, and school-based health centers and the professionals who work in both are great resources for parents to go to ask those kinds of questions.
And so just continuing along the lines of talking about school-based health centers, you mentioned in your remarks that FQHCs are the primary resource for helping to staff those centers. Can you talk to me a little bit about the workforce? What are we learning
Sure.
when it comes to burnout?
Sure. And back up just half a step. The majority of school-based health centers are sponsored by federally qualified health centers. The rest are sponsored by hospital systems, public health agencies, nonprofits, in some situations by school districts themselves. But the vast majority are federally qualified health centers, and that number is growing every day. Workforce is a huge issue, particularly in education. I was on a panel with the superintendent from Flint, Michigan last summer, and he said his number one issue was bus drivers. And we all thought, what are you kidding? And now you look, there's a national shortage of bus drivers. There's also a shortage of custodians. Denver had an article in the Post the other day that they were losing school nurses and couldn't attract anybody. Why? Because the hospital systems were offering $25,000 signing bonuses and $20,000 more in salary. Those of you who are on this call are heroes. You do what you do, not for the money. You could make more money doing other things at other places, but you do it because you're called to serve where you're serving. And we applaud you for that. I often say that Congress could give us the money to open those 25,000 school-based health centers right now. We couldn't staff them. We're going to have we have two issues right now. One, and I had some numbers up earlier, 100,000 K-12 public schools. There's only 37,000 school psychologists, and that was before the pandemic. Only 43,000 social workers, only 96,000 school nurses, and a lot of those are part-time, 118,000 school counselors, and only 3,000 school-based health centers. The dilemma is the ratios. It's great that the great state of Delaware, my former home, mandates that every school will have a school nurse. The problem is, what if the school has 1,500 kids? It's not enough to have one school nurse. You need 3, 4, 5 school nurses to serve that large of a population. Same with the other health services. So that's one issue. There's not enough of us. So the challenge then becomes, how do we attract people to the field? You also have the problem of attrition right now. A lot of people are just hanging up their stethoscopes and going home. They're saying, I can't do this anymore. I'm eligible for retirement. I'm going to take it. Or they're taking that money to go to the hospital down the street. And we understand that. That's a problem. But the majority of school-based health workers are white women. And all of my colleagues in school-based health will acknowledge that it is really critical that if we're going to serve populations of color, part of health equity is that we have people in those positions who look like them, who speak their language, who come from their communities. Well, we're not like Teach for America. We can't go out and grab a kid out of college, give them 6 weeks of training and throw them in a classroom and say, go teach. We have to have licensed, certified, trained professionals. If we're going to attract kids of color and kids from underserved communities, we got to start in middle school, exposing them to STEM in high school and helping to guide them into college programs and university programs where they can get those certifications and degrees. But we've got to make sure that they're able to do it with no debt. I know how many of you are on this call right now, still suffering with the student debt to get to the position that you're at. It's not fair. It's absolutely not fair that you took a lower paying job and you're still carrying the same debt as your colleague down the street, making more than you with a big fat signing bonus. So we know these are issues we have to address, and we're all at the national level working diligently to try to address those workforce issues. But I'm not going to kid you, it's going to take us a decade. It's going to take us a decade to take those kids from middle school and bring them back to the schools they came from and the communities they came from. And we're just all going to have to figure out how to work together and make do until then. So,
Robert, you have taken us to school, so thank you. This lecture is right on time, as you can see by the comments in the chat. So given that our communities continue to face uphill battles with regards to resources and connecting with families and children in general, Venus, I'm wondering if you could talk about strategies that promotores and community health workers can try maybe with regards to specifically to school-based vaccines, taking into account Robert's remarks.
Yes, and I know that after this call, Robert and I are going to get together because I see a future for community health workers to be integrated into the school system. We have a shortage of teachers, we have a shortage of nurses, and we have a shortage of a lot of counselors in schools. And that's where our children spend most of their time during the day. I think it's important for community health workers to be there, not only as a sounding board for the student, but also for a good messenger, cultural messenger for the parents, especially if they're from another race or ethnicity. So I think promotores and community health workers are well trained, they're great listeners, they're very empathetic, they know how to reach the community. Like I said earlier, they've lived some of those barriers, so they understand some of the mistrust issues that we're going through. But sadly, I must tell you, this is just one of those things that I just don't like to share, but our call center, the calls that we've been getting, many of the parents are saying they're not going to vaccinate their children. They just feel that they are young, they have too much to lose. And unfortunately, unless we use that money, instead of pouring a lot of money into institutions that are going to do more research, put the money into minority physicians and minority pediatricians and minority schools, and schools that are really, like Robert said, schools that really need that diversity in that school, for the parents to understand a little bit more that they don't have to mistrust the system, that the system's there to protect them. And again, our goal is to continue to develop training material to get it out to all communities of color, but more importantly, any other agency or organization that would like it. Our training is for free. So please, our goal is to really get our promotores and community health workers integrated into not only in the school system, but in federally qualified health centers. And by the way, one of my training classes was almost all of the employees of one of the federally qualified health centers here in Houston. So I applaud those executive directors of the federally qualified health centers who are actually wanting to employ community health workers, because they're coming to us for names. So I think, again, going back to what I've said all along, we need to have these community health workers trained and integrated into all aspects of health and wellness.
Thank you, Venus. So, Kevin, I'm coming to you next. Thinking about the conversation with children's vaccines always has to be about, is really centered on the classroom. I'm wondering if you can help us understand what would be the percentage number of children vaccinated that we should aim for to feel safer in schools?
Yeah, so I mean, I think you're getting to a question that many folks have had along the way is, how can we get to herd immunity? Like what specific percentage of people being vaccinated or having had COVID-19 will allow us to get out of this pandemic? And I don't know we have a specific percentage at any point during the COVID pandemic because of these, for a variety of reasons, one of which is the changing variants like Delta. So I don't think we have a specific number, at least I don't have one in mind. We can certainly go back and see if any of those are in the CDC school guidance. But I think the overarching message is that we need to get as many children as vaccinated as possible, and that CDC and others have made kind of multi-layer recommendations, including masking and distancing and making sure we're identifying people who are sick, and that vaccination kind of fits into that overarching strategy to allow our children to go back to school safely. I have a middle schooler and a high schooler, and so hear about this kind of stuff on a daily basis. So definitely understand that it is important to kind of take all those into account when it comes to getting our kids into school safely.
Thank you. So a large part of the conversation around health equity and racial health equity centers around how we understand data, how we collect data, how we are able to disaggregate data, and how informative it is. So a couple of questions that have come to me from the listeners. One, how are we prepared to collect accurate data regarding vaccine status of children overall? And then the follow-up question to that is, I'm wondering if there is an opportunity, or if there's infrastructure in place to better understand the qualitative data, specifically what's working with regards to messaging and getting parents and children on board with vaccinations, or what are we learning? And I'm going to ask both Lauren and Kevin to weigh in on those questions. And Lauren, why don't we start with you?
And what's the of those questions, what would be the one that you prioritize?
I think the first one, with regards to the importance of quantitative data. Why is that important for us to focus on? And just what is your understanding of the lay of the land?
Well, I think it's important because, as I think Venus was mentioning earlier, parents do want to feel confident and want to understand how medications, or in this case, vaccinations, how they were developed and why they are safe. What's interesting about this particular vaccine is I think there's been more focus on the safety issue because it seems like it was so rapidly produced. And so there's great data about why that was and how all of the work on mRNA vaccinations was happening before the pandemic. So we're able to sort of latch onto that and leverage that. But people may not understand that process. And so data about that can help address some of the fears and concerns. I think that the specific data around, complications, around, long-term impact, all of those things will be really important to monitor so that people have a sense that there's transparency. People want to know that there's nothing being hidden, or people aren't trying to sweep anything, under the rug. So, and CDC, I think, has done a tremendous job in reporting back and publishing the data that's available so that people can look at it. One thing that I will say is that the data that's coming from many states and jurisdictions doesn't always have race ethnicity data included. So that means that even though I started my remarks saying that, kids of color are most at risk, they may be the ones that we have less information about if those patterns persist. So as we think about the vaccination process, I would encourage us to also think about how can we make sure that we get complete information about the kids and families that are getting vaccinated, so we'll be able to answer the question, is this happening in an equitable way?
I appreciate that. So my question for you, Kevin, just sort of building on that, try to make sure I ask it the right way. So as we think about data or dashboards and reporting out vaccination rates and numbers for children, is it possible for us to understand that data by school system or district or by school? How should parents be able, what's the practicality or the likelihood that parents will be able to better understand the vaccination rates for children in their schools? Is that possible?
Sure. So I think for the most part, when CDC presents data, it often does not go lower than either the state level or the county level. And so we really defer presenting any more granular levels, so data by school or school district, to the local or state jurisdictions and governments. And that's because, that's their data. And we want them to feel empowered to own it, and we don't want to overstep our bounds. So I wouldn't anticipate that we would present data on that granular level. But what I will say is definitely recommend that folks go to the CDC COVID data tracker. That's a fantastic resource. I have it pulled up right now. It does list a variety of data sources, including health equity data, PEDS data, vaccination cases, et cetera. There is a link to your community, which will bring you down to provide some information to your county level. But also, we have just such tremendous colleagues at the local and state health department level. And so I would definitely recommend that folks go to their local and state health department to see what's available on their websites. And also potentially, I'm not sure if some local and state jurisdictions may have schools that present that information as well. So that would be another source to consider looking into.
I would like to ask this question. I like to open it up to the panelists to respond to this question. We tend to focus a lot of our conversation around children that are have parents in the home or caregivers in the home. But for those children that might be in government custody and state custody, how should we be thinking about vaccinations for them? Are there any concerns or opportunities that you would like to maybe lift up to this conversation? Robert, I hear you. I see it. I see your brain waves working. So I'm going to come to you first.
My interest was in answering on the data issue. I'm not sure I'm qualified to speak to the question.
Well, why don't you go ahead with data, and I'll come back to the other speakers on the question.
Yeah, I really appreciated Kevin's comments and Lauren's comments. I can go to the NCES and the education department, and I can tell you just about everything about that school. I can tell you the demographics, I can tell you the test scores, I can tell you all kinds of things about that school. I can't tell you anything about school health in that particular school. I can't tell you what kind of professionals are there, what their capabilities are, what services are being offered in that school. There is no national census on what's happening in schools around health. That's a tragedy in the third decade of the 21st century. We've got to do something about that. We also have these behemoths called HIPAA and FERPA that scare the heck out of people. Let me first tell you that the former Deputy Secretary of Education under the last president told me that no one's ever in history been prosecuted for a FERPA violation. So before everybody goes running and hiding behind FERPA, it's not a real issue. Second, we're in a public safety exception. That's the one exception where folks in the HIPAA and FERPA world can share information. Currently, a private pediatrician can't share healthcare information with what's happening on that child with the school. The folks in the school-based health center working right there side by side with the school, technically in a non-pandemic environment, can't share what's happening with that child with the school because we have these HIPAA and FERPA firewalls between us. Those need to come down. But it all needs to start with data. Let's just start with a simple census telling us what's happening in every school and what resources are available in that school. That will then help us target where we need to put resources. We can't just assume that every school has a nurse. It doesn't. Or that every school has a school-based health center. It doesn't. And we don't know, and every school-based health center doesn't offer the same services. And then there's the last point here, and that's what we in our space call working to the top of your license. Please stop asking school nurses to do telehealth. We can train people in 6 weeks how to do telehealth. We don't need a school nurse who's already swamped to do that. We've got school psychologists doing tests. I don't have a problem. I mean, school psychologists should be evaluating the test, but giving the test? We can have somebody else give the test and allow the school psychologist to do the things they've been trained to do. It's a flaw in our system, and it's something that we've got to take care of. But it all starts with data. We can't even tell you who's doing what where, and that's a tragedy in this. And we can collect all of this data. We're just not doing it.
Thank you. I appreciate that, Robert. Coming back to the question that I asked before Robert's last comment, I'm wondering if how we should think about students that are in government custody, state custody, with regards to educating their guardians, so forth and so on, and educating them with regards to vaccines. Lauren, I'm wondering if you could start, please.
Yeah, I know you raise a really, really important question because that is a group of young people that really do need a specialized approach. I think I have two comments. One is ideally the state Department of Child Welfare, or however it's organized in the state, could and should be in collaboration with the State Department of Health around the particular needs of that cohort of children. Usually those kids are covered under the state's Medicaid program, so they should be able to see health providers. They're also usually required to have at least a medical assessment, so there's at least a potential for a medical home. So in some ways, those kids ideally should have a network of pediatric providers that have seen them at least once to do the medical assessment and who could follow up with them. So I think that the connection with the public health department, the connection with the medical homes that have been sort of assigned to those children, and then think about the child welfare organization needing to have a concerted effort to reach out to the foster families and other guardians of the kids that are in their care to ensure and make it easy. And again, making the access easy for those guardians to get the children vaccinated. The issue about consent and who gets to make that choice is a separate issue, which I think is not what you're asking about, but it's because things around medical decision making would be in the best interest of the child, and the agency would be charged with doing that. So hopefully in concert with the public health department, they would develop a protocol for that. The only other thing I would say is in group homes or other congregate settings where there might be kids living, then again, special outreach there to ensure that those children are reached either through mobile vaccination vans or connecting them to a particular health center to make sure that they get those services.
That's very helpful. Thank you. Kevin, I was hoping that maybe you could speak to us about, I just lost my train of thought. But nevertheless, I'm wondering if you could help us understand how we should be, how we can work with, how we can access your resources, and also work with our local health departments to what is the best way that we should be approaching a partnership with our local health departments?
Sure. So I think ideally that would build on relationships that already exist, right? So either relationships that existed before the COVID pandemic, or relationships that have been developed and strengthened during the COVID pandemic. We know the pandemic has definitely brought a lot of people together. That's one of the few silver linings of the pandemic, I think, is getting people together to work on such an important topic. So I imagine many community groups have connections to local or state health departments now. If you don't, I would recommend looking for trusted messengers or those key partners who may work with the local and state health departments closely. And that could be in a variety of settings. We've heard a lot about the school setting today. I'm a pediatrician, as I mentioned. I know the AAP state chapters are very active and very engaged. So that could be a resource as well. So I think it's just a matter of looking around and trying to figure out how you can plug in. And oftentimes it can be a matter of just like volunteering to help on something. That's frequently how people get involved in the AAP state chapters, is saying like, hey, I'm here. I don't know much about this topic, but I want to help out. So I would recommend all the experts on the line here with their great expertise could potentially reach out and offer their assistance and really try to get engaged in that.
Thank you. And Venus, so lots to talk about. Earlier, you showed a map during your comments, during your presentation. And I noticed that your organization wasn't located where I live, here in Nashville, Tennessee. And I also understand that how we approach solutions in communities differs in rural communities versus urban communities. I'm wondering if you could sort of share your thoughts about for the viewers on how we should think about engaging with community health workers in rural communities versus urban communities. In addition to that, if you can also consider undocumented individuals from a myriad of different backgrounds, Haitian, so forth and so on.
Well, yes, we are all over the United States. We'd love to be everywhere else. I mean, there's some cities and towns that we'd like to get in and work with whoever is actually working in, not only in the school, but in the community, to empower them with whatever tools we have, because we're all in this together. I mean, one thing we've learned about COVID, it doesn't care about race or ethnicity or gender. Or age, it's an equal opportunity killer. So I think in our case, we have been very open about the fact that we are accessible to our community, but we are also accessible to all of you on the call. Let us know how we can help, how we can set something up to set up our training. And I'll tell you, community health workers and actually promotores have been around for decades and decades. This is not a new thing. It's just that now they're being recognized for their work, but they've been around even during the 1960s in the migrant communities, that one person who was able to share information about health and wellness to the migrant workers in the fields. So we've been around for a long time. I think we will be there a lot longer. I think if the problems are in the community, the solutions are with a community health worker and promotore. So I just, again, feel like this is our time as community health workers and promotores to have our voice. And we work on 4 different, our task is divided into 4. We call it the MIND framework. And if this is something that you can apply to your community organizations, it's great. It's the M for motivating your community. How do you motivate your community to get early detection screening, not only for diabetes or cancer, but also getting that COVID testing and the vaccine. The I is for informing. How do you inform our community in a culturally and linguistically appropriate manner about all the available resources in the community? And navigators. I mean, we need our navigators in the community to navigate people from, for the access to care, access to vaccine sites, access to better information and communicating in a culturally linguistically appropriate manner as well. And lastly, educating. We need more community health workers out there in the field. We're ready to educate them, but they are the ones that really can educate our community and be mindful of every community that they go to, how to bring down the volume of their training, not have training that's way over people's heads. I mean, we really need to look at our community, and before we get in there, tailor our community intervention or our community education program that's very tailored to that specific community. One size does not fit all.
Thank you. Thank you, Venus. I agree. One size does not fit all. And we're here today sharing information and learning from each other, learning from our speakers. A lot of great information in the chat. I haven't been able to keep up with everything, but we're going to be taking notes. I just want to say thank you to our speakers. And before we completely close out, if we can just go around quickly, and if there's just maybe one or two words that you would like to give as a call to action for our viewers, our listeners, what would that be? Or what would you want them to pay attention to as we are moving towards the potential vaccine rollout for ages 5 to 11? And I will start with you, Robert.
There's no wrong doors. Whatever it takes. If we can distribute it at a pharmacy, at a school, at a pediatrician's office, at a church, I don't care. Let's get the vaccine out. And for the record, I'm for mandates.
And thank you. Venus.
Misinformation plus miscommunication equals mistrust.
Thank you. Kevin.
I would just recommend talking to your family members, your friends about the vaccine. If they're vaccine hesitant, ask them what they want to know, serve as a trusted resource to your immediate network and encourage the folks around you to get vaccinated. Thanks.
Thank you. And lastly, Lauren.
Two snaps to everything that my panelists colleagues said. I think I would just add, from my point of view, that if you do the planning with a focus on equity, you're going to be able to be more effective, not just for those children of color who are at increased risk, but when you decrease the burdens and increase the access, it ends up being overall beneficial to the whole population, that sort of targeted universalism. So I would say equity has got to be front and center in how the plans are developed.
Thank you. And I would add, to continue the conversation, continue asking questions, continuing to work with each other outside of our silos. Thank you to our speakers today. We will follow up and send out the slides, the information towards the end of this week. There will be a survey that you will receive towards the end of this call. We are here for you if you have any questions. Thank you to the CDC Foundation for allowing this conversation to come forward. And thank you for those that helped make this Zoom webinar happen. Please have a good afternoon.